Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
You know, pulmonary hypertension is so much more than just a number you see on a diagnostic report. It's this relentless, dangerous increase in pressure in the pulmonary arteries that puts the right side of the heart on a collision course with failure. So today, we're going to break down the pharmacology we use to fight back. The goal here is to give you a really clear, logical framework for these drugs so you're ready for your exams and for clinical practice. So here's our game plan. We'll start by making sure we're all on the same page with the pathophysiology. Then we'll move step by step through the treatments, kicking things off with the first-line agents, then diving deep into the targeted therapies that hit specific molecular pathways. We'll also cover the supportive care that's so crucial for managing complications, and we'll wrap it all up with a high-yield review to make sure the most critical facts really stick. So what exactly is pulmonary hypertension? Well, clinically, it all boils down to one critical number, a mean pulmonary arterial pressure of 25 millimeters of mercury or higher while at rest. That number, right there, is the magic threshold for diagnosis. It's the starting point for this whole discussion and, for sure, a classic value to lock away for any exam. And look, this isn't just about high pressure in a pipe. It's a pump problem. Think about it. That high pressure in the pulmonary arteries means the right ventricle has to work incredibly hard, day in and day out, just to push blood into the lungs. Over time, that chronic strain, that pressure overload, leads to the ventricle getting bigger, weaker, and eventually failing. That's the life-threatening domino effect we're trying to prevent with these drugs. With that in mind, our goals for treatment are really all about the patient. We're not just trying to bring down a number on a chart. We're aiming to relieve symptoms like shortness of breath, help them walk a little further, slow down the disease itself, and at the end of the day, just give them a better quality of life. Every single drug we talk about today is a tool to help us get there. All right, let's get into our first class of drugs. Now, for a very specific group of patients, the ones who show a positive response during vasodilator testing, our first-line agents are the calcium channel blockers, or CCBs for short. So how do they work? It's a pretty elegant mechanism, really. Calcium channel blockers like the prototype nifedipine work by blocking the L-type calcium channels on vascular smooth muscle cells. When you block calcium from getting into the cell, you get less muscle contraction, which means you get smooth muscle relaxation. This happens all over the body, systemically, but also, crucially for us, in the pulmonary arteries. That vasodilation directly lowers the pressure. Simple as that. And here's the key point. That same mechanism is what causes the side effects. Because CCBs cause systemic vasodilation, not just in the lungs, you get things like headaches from the vessels in your head dilating, a reflex tachycardia, and that absolute classic exam favorite side effect, ankle edema. That's caused by vasodilation in the tiny arterioles down in your legs. But, you know, it's not always that simple. The majority of patients actually don't respond to calcium channel blockers. And that tells us their disease is being driven by pathways that are a lot more complex. So for these patients, we have to bring out the big guns, the targeted vasodilators. These are drugs specifically engineered to hit the exact molecular signals that are causing all the problems. Okay, our first target is the prostacyclin pathway. Prostacyclin is a powerful, naturally occurring vasodilator. But in patients with pulmonary hypertension, they just don't have enough of it. So the prototype drug here is epoprostenol, which is really just a synthetic version of prostacyclin. We're basically just replacing what's missing. Now, when you look at epoprostenol, a few things really jump out. The mechanism is simple enough. It's a receptor agonist. But the pharmacokinetics? Wow, they're a huge challenge. It has a super short half-life, which means it has to be given as a continuous IV infusion through a central line. That's a massive burden for the patient. And for your exams, you gotta remember those classic adverse effects: flushing, diarrhea, and especially that high-yield buzzword, jaw pain. Let's switch gears to our next pathway. Endothelin-1 is one of the body's most potent vasoconstrictors. It's a real bad guy in this story, and its levels are way too high in pulmonary hypertension. So a pretty logical strategy is to just block its effects, right? And the prototype drug we use to do that is bosentan. So, bosentan is an endothelin receptor antagonist, and right away you see a huge advantage. It's a pill you can take by mouth. That's a game changer. But, and this is a big but, its use is really limited by a major side effect. It can be toxic to the liver. It causes elevated liver aminotransferases. This is a huge deal. It means patients need regular liver function tests, and it's an absolute contraindication for anyone with liver disease. This is a must-know clinical pearl. All right, on to our final targeted pathway. This one involves nitric oxide and its partner, cyclic GMP, or cGMP. Now, cGMP is a powerful vasodilator, and we have two totally different kinds of drugs that work to increase its levels: the famous sildenafil and a newer drug, riociguat. And this slide illustrates the different mechanisms perfectly. Sildenafil, a PDE5 inhibitor, works by stopping an enzyme from breaking down cGMP. Think of it like it's blocking the brake. Riociguat, on the other hand, is a soluble guanylate cyclase stimulator. It works by directly telling the enzyme to make more cGMP. It presses the gas. So see, they both get you to the same place, more cGMP, but they take completely different roads to get there. And that difference brings us to an absolutely critical, non-negotiable, red alert contraindication. Because these two drugs boost cGMP in different ways, using them together is like flooring the gas pedal while also cutting the brake line. The combined effect leads to a massive, dangerous buildup of cGMP, causing profound, life-threatening hypotension. You never, ever use them together. Okay, so beyond those core vasodilators, we also have our supporting cast of therapies. These drugs don't really target the high pressure in the lungs itself, but they're essential for managing the consequences and complications of the disease. The two mainstays here are diuretics and anticoagulants. We use diuretics, like furosemide, to help manage all the fluid overload and swelling that happens when the right ventricle starts to fail. And anticoagulants, like warfarin, are crucial because this disease creates a state where blood clots are more likely to form in the lungs. We use them to prevent that from happening. All right, let's pull it all together. Time for a high-yield summary. This is where we'll connect the key drug classes, their mechanisms, and that one red flag side effect you absolutely have to associate with each one. Let's do a rapid-fire review. First up, calcium channel blockers. They inhibit calcium channels, and the classic side effect is ankle edema. Got it? Next, epoprostenol. It's our prostacyclin agonist, and you need to remember jaw pain. Third, bosentan, the endothelin antagonist. The red flag? Elevated liver enzymes. Fourth, sildenafil, the PDE5 inhibitor, is famously associated with blue-tinged vision. And finally, riociguat, the SDC stimulator, carries that huge risk of severe hypotension if you mix it with a PDE5 inhibitor. So let's end with a clinical scenario to really lock this in. A patient is on riociguat for their pulmonary hypertension, and they need treatment for erectile dysfunction. Why would prescribing sildenafil, a super common ED drug, be a potentially fatal mistake? Well, the answer, of course, is that synergistic effect on the cGMP pathway. Giving them both would be like pressing the gas and cutting the brake, leading to a catastrophic drop in blood pressure. Understanding these pathways, it's not just about passing exams. It's absolutely critical for keeping your patients safe.